Well, welcome back yet again, everybody. This is the fourth and last of this year's installments of the annual Montreal Oscillometry Seminar. Once again, we've got a great program lined up, and I won't delay too much, but just a quick run of some slides here. Again, industry partners, thank you very much for helping to make this happen. We've had 165 attendees from 22 countries so far. And a tentative announcement that we will do it in person next year, either July 26, 27 or August 2 to 3. We'll try and pair it up to some other event in Montreal to make your trip doubly worth the while. The last week's seminar is posted once again on the Respiratory Effectiveness Group website. So thank you, Michael Walker. And this one will be posted within the week as well. Here's the program, ever changing. But we'll just get right to it. And that's the slide for the end. So I will stop there. And it's with great pleasure that I'm going to have Francine Ducharme, from a colleague in oscillometry from Montreal and a fellow from the Respiratory Effectiveness Group. She's going to be presenting on pediatric reference values for respiratory sinusoidal oscillometry in children aged 3 to 17 years. And Diane Gray from Cape Town is going to be moderating. So ladies, the podium is yours, and we look forward to your talk.
Thank you so much. Do you see my screen in
perfectly?
Yeah, very good. Okay, let's see how that moves. Okay, so these are my disclosures. So I want to go back in time as well. So my experience began in 1992 when my needs were to find an objective measure of lung function test to test interventions in acute asthma in the emergency room. And I specifically wanted to include preschoolers because at the time, the eligibility criteria for any trial was to be able to do spirometry. So therefore being 6 years and over by and large. So I wanted something feasible, something reproducible, and something sensitive to change. And so I went to my good pal, Mike Davis, who unfortunately passed away in 2008. And I asked him, what is it that I could use? And he dusted off an old oscillator by Jones Incorporated. And so we tried to make it work. And I said, okay, I need something like that. And I was finally able to find the Custavit R from Custamed Germany that provided monofrequency at 8, 12, and 16 hertz. And I tested feasibility, the reproducibility in acute asthma in preschool age children who were untrained. I documented that it was sensitive to change, and I did trial. And of course, because this was a new instrument, I did with my colleagues the reference values on a Custavit for Canadian children. And we really focused on resistance at the time, 8, 16. And that was our value that was totally in line with the others we're doing. And then we acquired the master screen iOS. I was at the children. I see Larry on the call. So you, of course, you know all the master screen iOS. So we did the reference values as well for Canadian children, and ours is here, the little triangle. And because we wanted this to be mostly, I'm not sure where I'm going back, but because we wanted to be mostly used in young children and of course, school-age children, because they also had trouble doing oscillometry in acute asthma, we went all the way up to 150 centimeter, but yeah. And then, of course, on the market, there's many more instruments now that appear. There's Tremoflow Respond Pro that are licensed in Canada, the M1 from Chest and the 2M. And so the ones that we have in Canada are these ones. And so we decided to set and do reference values for these ones. And the reason for these is because, of course, we've been using reference values from various devices on other, elaborate on other device onto a separate device. And I wanted to check the interchangeability of the reference values for different devices. And the reason why we ended up having to do or decided to do reference values specific to Tremoflow and Respond Pro was because of this study. So we did a study that I presented here at this seminar about 2 years ago. And we wanted to know whether Tremoflow and iOS value ended up to be the same. So we had 50 asthmatic children. We randomized the order of testing Tremoflow versus iOS We all tested the same signals of 5, 10, 15, 20, 25 hertz. And each test was done by two independent technicians so that there wouldn't be any issue with selections of curve. And we ended up, of course, as we expected, with really high agreement in resistance, good agreement in reactance. But there was absolute within patient difference of the order of 0.05 kilopascal per liter per second for all oscillatory frequency that were above 5 hertz. And we also observed a proportional bias that was 30% or more kilopascal per liter per second, per kilopascal per liter per second. So for every 1 kilopascal per liter per second, there was a proportional bias. And of course, the highest resistance, and I'm going to show you in this one. So this, for example, is showing the difference between tremor flow and IOS. This is at 5 hertz, this is resistance, this is reactance. You see at 5 hertz, there is no significant difference. The mean difference here is minus 0.01. Of course, it's not significant, but you can tell there's a little bit of a trend here that's not significant, with the beta being 0.13. But when you reach, so that's not an issue. But at X5, there is a proportional bias. So the difference by and large, I mean, a systematic bias, the difference by and large is about 0.17 kilopascal per liter per second. That's significant. And you can see the difference here. So the lower the reactance, the higher, the greater the bias. And if you skip to R25, you see the same trend. So a proportional bias, a large proportional bias for reactance. And how does that translate to? So so you have here the measure value measured on iOS at 5 hertz, the projected value measured on the tremor flow. And you see for a 4 years old, 105 male, depending on the resistance value, the highest the resistance value, the highest the difference in the Z-score. And you may argue that that's probably not a big issue. This is elevated, of course, and the Z-score is above 1.64, so this patient would be classified as being abnormal anyway. But you can tell, and this is at 8.5 years old, but you can see for R10, for any of these value, 0.75, 1, 1.25, 1.5, you have larger and larger difference in Z-score. And of course, going back to the paper by Ron, who tested the difference between instruments with different test charts. So of course, in adults, you would get, we'll see the M1, so large volume, low resistance. There's not much of a difference between instrument. But when you reach, 0.84, which comes to be around where you would see kids and even higher, then you see greater difference. So we decided to do the tremor flow, do the reference value for both the tremor flow and the Restman Pro parallel. And we thought, based on Ron's paper, that they would be pretty similar. So, so we wanted to do a reference value that would be good for both instruments. So we recruited 300 patients. We randomized them to 4 signals. So there were 2 signals on the tremor flow, 537, 741, and 2 signals on the Restman Pro, so 511, 19, and 8 hertz. And this is what we found. So this is resistance, this is reactance, this is at 5, 11, 19. These are the exact same oscillatory frequency that we had for the 511, 19 and Restman Pro in green, the 537 tremor flow in yellow, and 741 in orange. And you see the distribution of points. And of course, if the child is quite tall, there isn't much of a difference here. But you can tell that as a child is shorter, there's greater difference. And that really caused problem, because you can tell here that the Restman Pro is significantly giving lower values than the tremor flow. And of course, the Restman Pro is also giving less negative value for the resistance. So there was a systematic bias. The value between device at R5 and X5 was in the order of minus 0.07 or 0.05. There was a proportional bias. So the greater, the shorter the patient, the greater the difference. And then, so we set up, and it took months for us to do that. So we, of course, we had strict adherence to calibration and data acquisition protocol. We had randomized the order, so that was not a bias where the child was getting more and more tired. We tested the order of randomization. It did not matter at all. So then we set up to have extensive post-acquisition quality control. So we added a value that was proposed by the RESPOND Pro, so the percent of acceptable breath, 50% or more. So we added that to tremor flow. We excluded all the values that didn't have 50% acceptable breath, so that they would be similar. We had independent review of all the curve selection, and we still ended up with the same thing. So this was a true difference. And so that was one point. So we had to set up different reference values. The other issue that we encountered was, if you can look here, so this is the dots, le nuage de points, for the resistant, the X5, and this is the R5. And you can tell, looking at the shape, that the variation is much smaller at higher heights than over here. And same thing here, much smaller here than at lower heights. And when we use the, so that was one important issue. So that meant that if you were doing the regular regression model with the standard deviation, which is here represented in the dotted line here. So this is the mean using the linear regression. This is the mean using the GALMS, which I'm going to talk about, but I just want to point out this. So if you look at this, the confidence interval, or the upper limit of normal here, you can see how high it goes with absolutely no points in this area. So that was a problem. And when you do, of course, the upper limit of normal, you anticipate that 5% of the dots, the points, will be above for resistance or below for reactance. And so we looked at the percent that was above the upper limit of normal by using the linear regression with the standard deviation in both. So this is reproduced in black. And you can see there's a problem here. For example, here, as I pointed out, there's no patients that are falling, no patients that are 125 centimeter or less that are falling above the upper limit of normal. And conversely, over here, there's about 16% of the patient dots that are falling outside the confidence interval. And over here, because the confidence interval is much larger, then there's almost no one that are falling above or below the confidence interval. So, so the linear regression definitely was not the good approach. So we adopted the same thing as is used in the, what is it called? The global, no, not the, what's the other thing? When we do all the spirometry, will come
GLI.
back. Yeah, that's GLI, sorry. Thank you. It's woke up at 5 o'clock here. Generalized additive model for location, scale, and GALMS, which is it's called in shape, and that's GALMS. So we were able to model both the mean independently from the standard deviation. And we ended up with something that was quite better, between 4 and 7% above the upper limit of normal for resistance, around 5 to 7 below the lower limit of normal for reactance. And so we've done this for everything. And this is how this compares now to other values. So this is the resistance at 5 Hertz by height. You see the RESPOND Pro here in blue. You see the tremor flow in orange. You see Al-Bushi, which is also for tremor flow in gray, which you can tell is pretty, aside from the beginning, you can see that it's pretty close to the tremor flow, and that makes sense. They're both the same instruments. And then this is Nova Whiska. And same thing for RESPOND here. So you have it in blue. There's no other comparison with RESPOND right now. So we compare with the I2M over here. This is I2M here. This is I2M with Calogero here. And then what's missing? This is our iOS in green here. So if we are to use reference values designed from another instrument, we will either over or underestimate the value in a patient. This is for reactance. Again, this is reactance at 5 Hertz. In blue, you have the Resmond Pro. In orange, you have the Tremoflow. And the line that's very, very close here is the other one, Albushi, that was also done with the Tremoflow. So they're pretty similar. For the Resmond Pro here, there's no comparison with another instrument, but it seems to fare quite similarly to the I2M. Now, what we've been using, or maybe personally I've been using since we started in 1990s, was really focusing on resistance at 5 or 10 or 8 or whatever the instrument was providing. And maybe at the time we didn't know, but we didn't focus at 520, X5. Of course, when it was monofrequency device, we couldn't do the AX and the resonant frequency. But I think that we had not been using the oscillometry to its full potential, not elaborating reference values for that. So of course, we're all doing that now. So we did the AX here, we did the resonant frequency as well. And just to close, I think what all this tells us is that we have to choose the instrument that we want to use. And because of the discordance in values that are measured in different instruments in the same trial at the same time, and that's due probably to different oscillometry technology, transducers, analytic algorithm, we're stuck with having to use instrument and frequency specific reference values. So there's tons on the Jaeger. I just put some of them. There's 2 now on the I2M, so Calogero and Hall. Tremoflow, there are 2. Resmond, there is 2 as well. And I know there's another one cooking right now. But we need to do the instrument and frequency specific reference values. And we have to keep the same references value within patients. So what are the future directions? So we have another study that we're analyzing right now, and we're looking, we're looking at the most discriminative combination of parameters, the one that will be able to tell us more accurately whether the child has mild, moderate, severe obstruction. And we think that it's not going to be just one parameter, but probably a combination of parameters. So we have a study of 250 acutely ill children that we're examining right now. We would like to be able, based on that study, to provide thresholds value for what is mild, moderate, and severe obstructions, just as we have for spirometry. We need also to identify the most responsive combination of parameter. I don't think, again, it's going to be only one. It might be a combination. And of course, as Ron has been saying for the past X years, we need to harmonize values measured across the instruments, because that is a lot of work to recreate all this. So, and this I'm close.
Thanks, Francine. So over to you, Diane. And just if we could keep the discussion maybe to 5 minutes or less. I just got a message. One of our last participants has a clinic full of patients and will be signing out on time. So if we want Dave's pearls of wisdom, we'll have to keep to the schedule, unlike other sessions. So go ahead.
Thanks, Ron. And thanks very much, Francine, for an excellent presentation and amazing research. As a clinician, a pediatric clinician, I'm really aware of the urgency of making these strong tools that we can interpret accurately for children. Particularly young children. And as a clinician working in Africa, I'm also particularly interested in reference ranges, because I'm working with populations that are grossly underrepresented in the literature. So fascinating, and I really I found your presentation and previous work so inspiring. I just wanted to highlight one thing that perhaps didn't come out in the presentation, but I thought was particularly interesting as well, was the lack of effect of ethnicity on the reference equations. We've just completed similar exercise using the wave tube in-circle setup on about 700 South African children, and showing the reference equation to compare very favorably with many of the equations. But where it deviates, and what you've shown too, is in children of very low height, and I mean, we had, I think, over 200 children under 120 centimeters. So we saw that, and and maybe I thought, we certainly didn't find ethnic differences so much and we noted the device differences, but certainly also modeling differences. So I was very interested in your slide on the Gamlis approach versus your linear regression. And do you think that is the main reason why your reference equation perhaps doesn't have that very steep height dependence in the lower, or do you think it's device?
No, no, because you can see with the two devices, we see the same thing. So I really think it's the modeling that makes a difference. We examined whether the young children had more, variation in their measurement, the repeatability, and they weren't. They were similar to the others. It is also possible that it's, reduced signal to noise ratio. But it's a fact of life. There's more variation in the little kids. And I really think, like, if we go back, I really think that we need to have the best, the stricter confidence interval, because these children here would be at, 1.5 would be considered normal, although there's absolutely no one in that, falling in that direction. So, we want to be able to, if this is going to be a diagnostic test, or at least we actually need to have, the lowest false negative that we can. And it's always a trade-off between, false positive is false negative. But in this case, we don't want to have that many false negative, definitely. I wanted to go back to the ethnicity. Yeah, I didn't allude to that, but actually, we thought, we were wondering whether, like in spirometry, there would be big differences in ethnic groups. And as you probably all know, the blacks, for example, for the same height, have longer legs and shorter trunk, and the white different. And so I thought that if we were to do sitting heights, we would obviate that. And so if there was to be any ethnic differences, sitting, the ethnic difference would go away because you're just measuring the trunk. And so we actually produced reference values for sitting height, hoping that would, eliminate all ethnic difference, but there was no ethnic difference anyway. So we did all this for nothing. But anyway, we published it and we said, look, if someone cannot stand because they have, whatever, lower limb fracture or whatever, anyway, they'll be able to use it. But yeah, there was a lot of work that went into trying to, avoid the ethnic difference that actually appeared to be non-existent. And I'm happy to see that you found the same thing, Diane.
Certainly with ethnic differences, they may actually represent many other exposures, not race. So I don't know if there are no comments in the chat, but I wondered whether Zolly might want to give his insights into this, because he has just gone through this process with us and very extensively compared the different published reference ranges. Zolly, are you there? Would you like to comment?
Yeah, thank you. Thank you, Francine, for this very elegant presentation, which had a great amount of history and work in the past to the present. So that was very nice to see. I want to comment on two things. The scatter and the confidence intervals approach is very, very tempting. What I am worried about is the formula you use for description of R5 versus height. It has an inflection point at low ages, heights, but instead of steadily increasing, your predictions are flattening. I thought it is indicative of the how to say, the process of growing up. So this monotonicity, which is in every other predictions, unless the linear, which are, of course, failing at both ends of the spectrum, so they can't be used for more than 10 centimeter height range, probably. So I think this mean value is a little bit, how to say, I don't feel it's strongly based. I don't think that any other curves which predict the increase steadily approaching shorter and shorter children would turn on. And just a minor question, not I would be very interested to read your paper in the pediatric pulmonology as well. And I was a little bit surprised by the title. Why does it contain the word sinusoidal? Because there is no sinusoidal at all. These are pseudo-random signals, or in the case of the iOS, recurrent impulses. So sinusoidal is cryptic for me in this study, and I don't see the point why you use this word.
So
but this is a very minor point.
Thank you for your comments. Look, for the sinusoidal, it was actually recommended to me as part of the study, and I went really fast in my disclosures, but we received a loan free of charge from Resmon and from Resmon Pru of 2 units, and we received 2 units free of charge from Tremaflow to do this. So you know, just as whatever part of the contract anyway, I asked them to review it, and they actually asked me to put this on. So I think you have to return the question to them. I'm really more a clinician than a physiologist, so I'll let them answer this. With regards, I'm sorry, it was cutting a little bit, so I didn't understand exactly everything. I actually turned off my camera because I was hoping that the connection would be better. I'm in the hospital, it's not perfect connection here. But I think you're talking about the use of height plus height square and the lack of this curve here. Is that what you were alluding to?
Yes, exactly.
Yeah. So we didn't want to have physiology guide us. We just wanted to have the dots guide us. And so just the spread of the values that we received. And that's how we ended up now on just an another, because there is a big difference between two. You're probably aware that Novoreska also reanalyzed her data on the iOS, and that was presented at ERS somewhere like in 2018. And they found reference values that were quite different from those that were published in 2008. And they commented on this, saying that probably it would have been better to use something that model like a regression line that modeled both the mean and the standard deviation differently, but it was never published. So I'm not sure whether there's anybody from that paper or that abstract that's on the line. It would be really nice to hear from them. But I really wanted to just follow the data.
Diane, I think at this point we're going to
have to move on. Yes, yeah. Sorry, Ron. I did see there are a couple of hands, and Jeff wanted to make a comment. Perhaps you could make your comments in the chat, and Francine can reply to them in the chat. Thank you so much, Francine. And I'm sorry we can't discuss this further. It's very important.
Okay, well, thank you both, Diane and Francine. And now, without further ado, I'm going to have Heather Boas from CHOP in Philadelphia take over the podium, and she's going to discuss with us AOS and iOS in normal children. Is all oscillometry the same? A very good question. And my friend and colleague from McGill, Larry Lands, who's the director of pediatric pulmonology or respiratory medicine at the Children's Hospital, will be moderating the discussion. So Heather, please take over the podium, and we look forward to your discussion and talk.
Great. Thank you so much. Everyone,
sorry, we need the mute police. Yeah, just a moment. We'll find whoever the offender is. Maybe Jeff has got them already. Good.
So
go ahead, Heather. Sorry about that.
Screen in presentation mode.
Yes.
Perfect. Well, thank you very much. And I can't think of a better presentation to precede mine. So thank you for that, Francine. My name is Heather Boas. I'm a pediatric pulmonology fellow here at the Children's Hospital in Philadelphia. I'm going to be presenting some preliminary data from a project that I've been working on with Dr. Julian Allen. So as pediatricians, unlike painters and artists in the Renaissance, we know that children are not just miniature versions of adults. They have very different physiology, which changes as they grow. So from a respiratory perspective, there are changes that occur as children grow, as their airways grow. For example, we see changes in compliance and elasticity. We also can see changes in spirometry. So there's decreasing expiratory flow rates as children are growing and decrease in FEV1, FVC ratios. And so similarly, there are trends in oscillometry that we see patterns between children and adults. Some of this is because of the higher airway resistance and smaller lung volume in children. So for example, one thing that we see is a pattern of decreasing resonant frequency with age. So here we can see some examples of general trends looking at resistance, reactance, resonant frequency. These graphs are comparing different studies. And while you see a similar trend across the studies, so for example, looking at resonant frequency at the bottom of the screen, there's a very general downward trend, but you can also see that there is a difference here across different authors and particularly using different instruments. And so, of course, there are many instruments available to measure oscillometry. There are lots of devices that we can choose from. Two that we often use here are the AOS system, the airwave oscillometry, and the iOS system, the impulse oscillometry. And both of these instruments are using the same principles of forced oscillation, but there are differences in the applied forcing patterns that they generate. So the AOS system is producing a sinusoidal wave, and then the iOS system here produces an impulse pressure, which is sometimes described as a fixed square wave. And you will probably recognize some of the names on these next few slides. So when you look at the literature, you can see, and as we just heard, people are starting to look at differences between different devices. So this is data from a study from Ron, an in vitro study looking at different mechanical loads using different devices. And what you see here is that there are differences observed. This is specifically looking at reactance, and you do see that there's a difference when you compare the different devices. And here's data from two additional studies. Both of these are in adults. These are bland Altman plots, which look for bias between the two instruments. So on the y-axis, we're looking at the difference between the AOS and the iOS. And then the x-axis is looking at the mean. So proportional bias is when there's a greater difference between the two at certain values. So if we look at the study on the left, this looked at reactance among adult healthy subjects, asymptomatic smokers, and adults with asthma. What you can see is that the overall difference between the means is relatively low. But particularly when you look at the patients with asthma, and these are the ones represented by the closed circles, there's proportional bias here as the reactances become more negative. And then looking at the study on the right, these were adult patients with COPD. Again, you can see that there's not a lot of difference between normal healthy subjects, but you do start to see more of a difference between the instruments as the reactance becomes more negative, and particularly in patients with COPD. And then here we just looked at this data in the previous presentation. So this was looking at children with asthma, comparing the AOS and iOS systems. And again, this was looking at reactance. So X10, you can see here the proportional bias. And again, we're seeing this more at the more negative reactances. And so really all of these previous studies led us to our research questions and the purpose of our study. So we asked ourselves, how close to each other are the raw values for resistance, reactance, and resonant frequency between the iOS and the AOS instruments in the same subject? We wanted to look at how well the data in our lab conformed to published data. And then how could this, as well as the predicted values used by the two instruments, affect the % predicted values in the z-scores? And so we're specifically looking at the AOS and iOS in healthy children. We're recruiting healthy kids born at term, age 4 to 18 years old. Our goal is to study 93 patients total. So far, we're about a quarter of the way to our goal. We've studied 23 so far. We have each subject perform both forms of testing. They do AOS and iOS. We randomize which order they're doing that. And we have them do up to 10 repetitions on each. And really, this is just to ensure that we get 3 studies with a good coefficient of variation. Each trial lasts between 20 and 30 seconds. And then we look at the waveforms to check for any artifacts such as leak or coughing or laughing or anything like that. Specifically, we're looking at resistance, reactance, resonant frequency in the two instruments, and we're looking at analyzing by correlation, lines of identity, and the Bland-Altman analysis. And so we're starting to see differences already. So for example, these are 2 graphs from the same patient using the 2 different instruments. So you can see that with the AOS, X5 is more negative, so it's negative 2.4 centimeters of water per liter per second. And this is compared to the iOS, oh, sorry, I did that too fast, where when you convert the units, this comes to approximately negative 1.7. And then the resonant frequency we're also seeing is higher in the AOS. It's about 20 hertz compared to 17 in the iOS. And I didn't mention on the previous slide, but we're using Tremoflow for the AOS systems and the Bayer for our iOS. And so then as we start to look at the data in aggregate, so here we're looking at the resistance. You can see R10. So we have a line of identity on the left. We have our Bland-Altman plot on the right. And you can see that there is very small bias. It's not proportional. In general, these 2 instruments seem to be correlating very well. We're seeing both correlation and agreement in our results. And I didn't put this up on the slides, but we did see very similar results with the R5 values as well. And then we start to see a little bit more difference when we look at reactance. So in contrast, here we're looking at X10, and it's much more varied. So when we're looking at the resistance values, they all seem to be very tightly correlated. Here we're starting to see more negative, more disparity, and we see that especially at more negative reactances here. And in particular, when we look at the Bland-Altman plot on the right, here you can see that there is proportional bias at the more negative reactances. And then this is also reflected and really even more evident in the resonant frequency. So again, we're seeing proportional bias. There's greater difference at the higher resonant frequencies. Additionally, we're seeing that AOS is giving higher values as compared to the iOS at higher frequencies. And then you can see that here in the Bland-Altman as well. And then here, this is looking specifically at resonant frequency. Again, here we're comparing it to age. So we haven't yet looked at height, but we are looking at ages. You're looking at the AOS system in orange. The iOS is represented in blue. And just as has been previously described, there's an overall decrease in resonant frequency with age. This is something that we've seen in the past. And we see this across both instruments, but we do see that the AOS tends to be higher than the iOS. You can also see that in the youngest age groups, there's a much wider range and there's greater variation between the 2 instruments. And so what we're seeing so far is that in healthy children, there seems to be excellent correlation between the two instruments when we're looking specifically at resistance. But we're starting to see differences in the reactances and the resonant frequencies between the two. So specifically, we're seeing greater difference in the reactance in AOS compared to iOS, and especially at more negative reactances. And we're also seeing greater difference in the F-res between the two instruments, particularly at higher resonant frequencies. So when you have a higher resonant frequency and a more negative reactance, this is consistent with a more stiff respiratory system. And so what this is looking like is that the AOS system is suggesting a stiffer respiratory system. And as we've already looked at, there have been other studies showing differences between AOS and iOS and different devices. But a lot of these studies have been in adults. They've been in children with disease such as asthma, COPD in adults. Our data is really suggesting that there's proportional bias between the two systems, AOS and iOS, in healthy children. And we're seeing this even more so in the youngest ages. So one possibility as to why we might be seeing this is that in both groups, both individuals that have diseased lungs and in children, especially younger children with healthy lungs, there's lower lung compliance. So we can't really say that AOS is overestimating or iOS is underestimating resonant frequency and reactance, but this data is suggesting that the normal values for one instrument may not provide predictive values for another instrument. I think the question still remains as to why we're seeing these differences, why we're seeing this proportional bias. One possibility could be that this is related to the different types of waveforms used, the sinusoidal versus the impulse waves. So I'm excited to hear what others' experiences have been. If people are also observing similar patterns, I think we've already just observed, or we've already heard about similar patterns in the previous talk. I'm curious what other people think about possible explanations for this as well. I would like to take a moment to thank all of the members of the team who are working very hard on this study, which again is ongoing. And with that, thank you. And I'm looking forward to the discussion and happy to answer any questions.
Well, thank you, Heather. That was a great talk and certainly segued very nicely with Francine's work. Larry, are you able to turn on your mic and camera? And
yeah, they're both on. And yes, thank you very much, Heather. And that was a great follow-up on Francine's work. There's before I just open up, both Francine's work and your own work showed that for smaller children there was much more variability, and despite taking all the precautions you can to make sure that your data was as clean as possible. And so why do you think there's so much variability when the children are smaller? And doesn't seem to matter which device is being used. They all seem to have more variability.
Yeah, that's a great question. Yeah, and we haven't specifically looked in our data at the size. And I mean, we're certainly theorizing that part of this is due to patient size because we're seeing it in the younger age groups. I think that's sort of the next step as far as when we're looking at the data and analyzing it, looking at height. So I think we will be doing that. I'm not sure why we're seeing that variability. Dr. Allen, I don't know if you have any theories that you have.
Yeah, I wanted to say one thing. I think, Larry, that's a great question. And I think it follows on what Dr. Ducharme showed when she talked about independent review of curve selection. I think that's so important. And, I think that it may be related to that because obviously younger children may have shorter attention spans. I think that it becomes a very important practical point because in a research study, you can have independent review of curves. Once this gets applied clinically in the PFT lab, I think it's going to be more difficult to have independent review. And I'd love to hear what Dr. Ducharme thinks about that as well.
Okay, David Kaminsky, you had a question or a comment.
Yes, thank you, Larry. Thank you, Heather. That was really great. I have a question that gets back to basic principles, and I'm not an engineer, so I'm hoping you or someone else can answer it. And that is regarding the waveform. When it comes to reactants, we spend an awful lot of time talking about elastance, but inertance also contributes. And I wonder if the sinusoidal versus square waveform difference results in some type of manifestation through inertance that is different between the two waveforms.
Oh, that's really interesting. Yeah, I mean, I spend a lot of time trying to look a little bit closer at the specifics of the waveforms that are generated. And I know that there is a difference, but I also do not have an engineering background. And so I don't know if anybody here has a little bit more experience in that. But I mean, I think that's a great point. And, you know, it's definitely something that we're thinking about, that there could be some kind of relationship with the waveforms themselves that are contributing to this.
So can the engineers, Zoli, Jeff, Eyal, make some comments here?
Theoretically, there wouldn't be expected to be a difference based on the waveform. Say if you were comparing test loads, for example, you don't expect that. However, the patients may respond differently to the sensations of the impulses versus the sinusoids, and the difference, that's one thing. So it could be an actual patient difference. You can feel the iOS a bit more than you can the oscillations with the other devices. But I guess I misspoke a little bit. If there's an amplitude difference, like, so theoretically, if the same amplitude is given, you know, the size of waveform in terms of peak to peak is given for both impulse and sinusoids, you wouldn't expect a difference. Higher amplitudes can give rise to different things, nonlinearities, high flows, and the iOS does have a higher amplitude as a result of its waveform choice. So it's possible there is a difference due to waveforms due to that, especially in higher impedance patients, which, like with smaller heights, you're going to get higher impedance. So it's possible. I don't know if amplitude has been investigated carefully, though.
Jeff, can I say one thing also? One thing we've noticed, and I think you and I have talked about this before, is that it seems that when children have higher respiratory rates, and even when Heather and I have tried doing this panting instead of just breathing at our normal breathing frequency, there may be a little more interference with the oscillating signal, and we've seen some tendency towards lower impedances at the lowest, at the lowest frequencies when we breathe quickly compared to the device. I don't know if that's playing a role also.
Okay, so in the interest of Francine, I'll leave the last comment and questions to you.
Thank you. So I just wanted to answer the previous question about the curve selection. And I guess in a nutshell, if there's something fishy, we need to repeat. And the reason I'm saying that is there's several reasons why, someone, you may want to select the curves. One is your CV is too high, right? And in danger, if the CV is too high, and it turns out that one curve is higher, the other one is in the middle, the other one is lower. If you exclude the lower curve, then you will overestimate, or anyway, you will increase the resistance. If you remove the lower one, the higher one, you will decrease it. There's a lot of risk of bias here, of systematic bias. So I think, we need to have as many curves as possible so that we don't end up having to choose, when they're all spread out differently. The other thing that we've seen is that sometimes we had a bend. In other words, the resistance at 5 hertz, for example, was lower than the resistance at 11 hertz. And so when it's almost the same, is it acceptable? Is it 0.2? Is it unacceptable? There's a lot of subjectivity in that. And I think this is signal to noise ratio. But what we did is when we saw a bend, we told people, you have to repeat, just keep repeating. And same thing with the AX, because I think there's a lot of hope that AX is going to be a very discriminative parameter, but no one looks at the CV of the AX. And you see when the AX is actually quite small, the CV may be like 50%, 80%. So you sort of want to believe this CV, this parameter. So you need to repeat. So I think there's a lot of repeat that has to be done at the data acquisition in order not to bias the selection of curves after that.
Yeah, we agree completely. And I mean, one of the reasons why we're doing so many trials with each device is in order to get as much data as possible. And we're not limiting the data that we're analyzing to the 3 best studies necessarily, or the 3 closest related. Even if there's a lot of variability in the same subject, we're using that as long as we're not seeing other artifacts such as leak or coughing.
Okay, great. Well, thank you very much, everybody. In the interest of time, I'm going to move things along. Just to say that Jolie had showed me a paper over the weekend that looked at different strategies of accepting various curves. And Jolie, I don't know if you were able to get your hands on it, maybe share it in the chat, but it's germane to the talk we just had. Again, in the interest of time, we're going to lump the next 2 talks together on the theme of COVID-19. And so that was the suggestion of Chung Wei, and it's a good one. So Laura, I'll have you and Chung Wei co-moderate both talks after Ivan Cherez from Ecuador presents on post-COVID-19 patients and their oscillometry results, followed immediately by Dave Kaminsky from Vermont. And he's going to talk about longitudinal COVID. So Ivan, it's with great pleasure I introduce you to the community here of the oscillometry seminar, and we all look forward to your talk.
Do you have my presentation this morning?
Okay, you can go ahead and share your screen, Ivan.
Do you have my presentation?
I have it on another computer. I was assuming that you would be able to do it.
Okay.
You'd have to give me a minute to go find it and load it.
Perfect. Give me 2 minutes, please.
Take your time. Good. We see your slide deck. Excellent presentation mode. Go ahead.
Okay. Thank you very much. First of all, I want to thank the opportunity for Ron, this opportunity to present our preliminary results. And when we have a lot of patients with COVID-19 in my country, always we have a difficult to measure oscillometry because we don't have a lot of devices with oscillometry. And when we analyze the different previous studies, we find a controversial report because one study said, for example, in the Finnish COVID-19 survivors in patients with where the finding had severe patient, when this study measured after hospital discharge 3 or 6 months, they didn't found any different when they using oscillometry. No evidence of a small airway obstruction. In this case, they had 22 patients. They use different measure of the oscillometry. When we review a Brazilian studies, they measure 2 months or 5 months. But when we looking the data, we don't know what kind of severity have this patient. However, when we use another devices, this measure, and this group found that there is a alteration of small airway disease, okay? Because they measure after 2 months and after 5 months. However, in this time, we had a different variant, probably Beta and Delta variants of COVID-19. But when we start a new wave of SARS-CoV-2, there is a new variant, this Omicron variant, and this variant have a different alteration pathways, and probably the distribution in tissue and organs influence in the clinical manifestation, because this variant has higher affinity for bronchus compared with another variants. And we start to receive patients after Omicron infection with persistence of symptoms. And we have a hypothesis, say, post-acute SARS-CoV infection with Omicron variants may induce a small airway dysfunction and contribute to persistent respiratory symptoms. We have objectives to prepare our study. In general, we want to evaluate a small airway dysfunction in the follow-up of post-COVID acute COVID-19 in patients with persistent respiratory symptoms affected by the Omicron variant, and we're using forced oscillometry technique. The specific objective will be describe demographic characteristics, describe the main symptoms associated with this small airway dysfunction, to classify by subtype of airway dysfunction based on VOT results, and to compare these results with fraction exhaled nitric oxygen. We prepare a PICO question. Our patient will be patient with Omicron with persistence of symptoms after 14 days. We measure forced oscillation technique, and we compare with exhaled nitric oxide test, and the outcome will be to measure the different parameters to measure the abnormality using forced oscillation technique. The material and methods, we prepare a prospective observational study in patients who attend our service and who will have persistence of symptoms, and we confirm that this patient has Omicron variant. And we measure fractional exhaled nitric oxide and VOT. When we measure VOT, we're looking for the parameters, and we consider normal according to the upper and lower estimate normal limits, or the CT score according to reference equation. And we use it in statistic, describe a statistic, and when will be necessary, we compare the result across different oscillometry categories. The inclusion criteria will be patient with more 11 years with diagnosis of COVID-19 confirmed by PCR, and we had persistence of symptoms after 14 days. And the exclusion criteria will be patient with, at the moment of attending, have positive for PCR or have inability to perform acceptable maneuvers of pulmonary function test, or if the patient have another variant. With this variable, we mention a predictor variable, demographic variable, respiratory symptoms, and our outcome variables will be the parameters of FeNO and VOT. And we have a preliminary result. We have 27 patients. The mean age is 15 years, and the median BMI is 25.28. And we have more of 60% of our patients has overweight or obese. We have principal women in our study. Approximately 27% of our participants have history of smoking, and 18 had pulmonary previous disease, asthma, or sleep apnea. And the main numbers of days after a COVID-19 diagnosis and the patient will attending in our service were 28 days. In general, the principal symptoms were cough, dyspnea, and fatigue. And when we look all of the VOT parameters, we measure resistance in 5 Hertz, This is the mean. The reactance is 5 hertz. This is the mean, median, and range. Pre-bronchodilator and post-bronchodilator. We measure two resistance 18 hertz and the difference between R5 to 19. I would like to remember our device have an algorithm. In this evaluation, they divided in 4 parameters: the normal, the peripheral obstruction, and the central obstruction, and the severe obstructive patient. We're using this algorithm, and when we use this algorithm, these parameters, we find these results. 52 patients of our patients are normal, and 27 have this peripheral obstruction. And it's interesting because in this case, we found the small airway dysfunction, and using these parameters, severe obstruction, we have 15%. And this is show us that there is a heterogeneity of ventilation due to a small airway compromise. And if we look the severe obstruction, in this case, we have a small airway disturbance plus peripheral obstruction. We have approximately more than 40 patients with a small airway dysfunction. When we look, compared with the results of FeNO, we have the mean value of FeNO is 27, and we know that results less than 25, we don't have airway, we don't have eosinophilic inflammation. And when we had more than 25, probably suggest that eosinophilic inflammation, and these results have implication in the management, in the treatment of the patient. Because our principal idea is how all our results to put in the real life in our patient in the clinical practice. This is the principal symptom that persists in our patient. All of the patients had cough, but for example, one of them had fatigue, and in central obstruction, we have wheezing, and if we are waiting for the patient had wheezing, probably we lost a lot of patients because it's not a frequent symptoms. And this is our conclusion. 4 of our 10 patients have a small airway dysfunction. The principal symptoms that persist were cough, fatigue, and breathlessness, and 33% of our patients have peripheral obstruction pattern when we measure this in this FeNO. We have more questions than answers because we think what we do in our patient. We use inhaling corticosteroid, we use bronchodilator, we use mucolytic, or we use all of that because the patient consult us for different symptoms and try to have the better treatment. And we think, or we believe that when we use when we measure oscillometry, could aid in the treatment decision-making in post-acute Omicron infection. Thank you very much for your attention.
Well, Ivan, thank you very much for sharing your experience with us. And the best talks are those that generate more questions than they answer. So we look forward to the discussion of your talk immediately following David's. David, if you're there, please turn on your camera and your microphone. And we look forward to your talk on longitudinal COVID.
Thanks, Ron. I'm here and I'm going to share my screen with you now.
Okay, slide deck scene.
Yeah. Let me just get this to slideshow. Now you're seeing the presenter, right?
Correct.
Hold on. Of course, it worked fine before. There we go.
You're on. Take it
We're
away.
good? Okay, thanks. Well, thank you, Ron, so much. It's a real pleasure to be here, and I miss seeing everyone in person. And Ivan, thank you for your talk. I look forward to sharing our results together. My name's David Kaminsky. I'm at the University of Vermont, and I'm going to talk to you about also our preliminary data so far on a longitudinal study that we're conducting on patients who have had COVID. And in case you're wondering where Vermont is, we're on the shores of Lake Champlain. And just to show you, Montreal is very close by. Hold on. There we go. I put that in there. If you head an hour north, you'll be at the Canadian border, and shortly thereafter in Montreal. We know that COVID-19 affects lung function. There have been a number of studies now to document this, and I'm just going to share with you a couple of them as background. These data come from Wuhan University in China, where they looked at lung function in 83 patients who had been hospitalized, and they looked at 3, 6, 9, and 12-month data. And on the left, you can see the forced vital capacity as a percentage of predicted at those 3 time points. And it's on average normal, but increases over time. In the middle is the diffusing capacity. And you can see the same thing, on average slightly below normal early on at 3 and 6 months, but increases with time. And on the right, the 6-minute walk distance in meters. And it starts off a little bit on the low side, but quickly improves to a normal range at 6, 9, and 12 months. These investigators also looked at dyspnea scores in their patients, and you can see at 3 months, most people had 1 or 2 on the MMRC scale, indicating more dyspnea, but as time went on, their dyspnea improved. And on the right-hand side, they characterized patients on whether they had a normal high-resolution CT scan or not. And you can see in those who had an abnormal scan, they had a lower diffusing capacity and a lower total lung capacity compared to those who had a normal scan. So these were some of the early data published on longitudinal effects on respiratory function. We've also seen other studies come out, again from China, in this case 110 patients who were looked at variably over a short period of time, 20 to 30 days roughly since discharge. And they found that the spirometry values, whether they had mild illness, pneumonia, or severe pneumonia, were normal. But the diffusing capacity seemed to track with severity of illness, with the patients who had more severe pneumonia having a lower diffusing capacity, and likewise a lower lung volume. Another study from China, once again, very similarly, looked at 57 patients, in this case, all 30 days after discharge, and they looked at the total lung capacity in their severe versus non-severe patients and found that the total lung capacity was slightly lower. I picked this study because and also diffusing capacity. This study also looked at oscillometry, and they found that the severe patients had a lower R20 compared to the non-severe patients. Finally, they also documented, as we saw before, that patients had a reduced exercise capacity if they had more severe illness, in this case documented by a lower 6-minute walk distance. Finally, the most recent study that I could find that's similar to my own is this study out of Canada that showed that patients had spirometry in the normal range in both hospitalized and non-hospitalized patients at 4 months after infection, but the values in the hospitalized patients were lower, again, albeit still in the normal range. Same for lung volumes, same for diffusing capacity, although now the hospitalized patients actually had a diffusing capacity that was less than the expected predicted value. And in this case, they did cardiopulmonary exercise testing, and they were able to document that these patients who were hospitalized achieved a lower work rate and a lower peak oxygen consumption. So the hypothesis for our study, which we developed back in early 21, was that patients with COVID-19 would have residual defects in lung function, particularly in gas exchange, based on some of these data, and particularly in lung mechanics, especially lung volumes. So we had 3 specific aims to focus on these features, the last aim trying to achieve an association between the two. And our plan at the time was to recruit 50 patients who recovered from COVID, and I did not limit it to inpatients. Rather, we included both inpatients and outpatients, and both those with and without residual symptoms, because I wanted to try to get a snapshot and understanding of what COVID was doing to the lungs in general. And our study was funded by a local grant through our hospital. So this is what the COVID prevalence looked like back in late 21 into 22, and this is the time period of our recruitment. So as Ivan was mentioning, there may be some differences between the various strains of COVID or SARS-CoV-2, and in our case, we're probably seeing still the Delta variant effects. And what we did was we recruited people whenever they contacted us. And so some of them were in early time periods since illness, 3 to 5 months. Others had already been sick for over a year and were now recruited to our study. And our goal was to then subsequently study them for the following year. And so we brought them into our clinical trials unit at the campus, and we studied them over the course of a year at baseline, at 6 months and 12 months, where we did a number of different measurements. Currently, the study is wrapping up this month with the last patients due to finish their 12-month visits at the end of the month, and I have some of the data analyzed that I'll be sharing with you. So these are the baseline demographics of our patients: 52 years of age, more women than men, obese, some smokers, but minimal smoking history. And some of them did have previous lung disease, particularly asthma. And the average length of their illness was 37 days. And the average days since their COVID diagnosis, remember I was taking all comers no matter when they enrolled, was 227 days. So that we were seeing them, some of them 6 months and beyond their original illness. When dichotomized to those who were hospitalized versus non-hospitalized to try to get a sense of severity of illness, we find that the hospitalized patients were a bit older. We find that they were heavier, and they had similar prevalence of underlying disease, though the numbers are small. They certainly had a longer length of illness at 44 versus 31 days. And interestingly, they had similar scores on MMRC scoring, as well as quality of life measures as seen at the bottom. We looked at lung function, spirometry, lung volumes and diffusion, and 6-minute walk distance. And here we found differences in the vital capacity being lower in the hospitalized patients, although still in the normal range. The TLC, likewise, and the diffusing capacity, likewise, still in the normal range, but lower than in those who were not hospitalized. And we did see, as has been seen before, a lower 6-minute walk distance, indicating some exercise intolerance. I was particularly interested in gas exchange, so we paid attention to the nadir oxygen saturation, and it was a bit lower, but not statistically so in those who were hospitalized during their 6-minute walk test. Then we stratified by shortness of breath, and we found that the vital capacity and the 6-minute walk distance were the only two parameters on conventional testing that stratified. We started measuring MIP and MEP later into the study, muscle pressures, and we also started measuring the first 100 milliseconds of inspiratory pressure, or P100 or P.1, as a marker of respiratory drive. And so far, with very small numbers, we're not seeing significant differences between those with shortness of breath versus those without shortness of breath. And then over time, in the patients for whom we have full data, you can see the hospitalized patients in orange, the non-hospitalized in blue. They remain within normal ranges, and they don't have any statistically significant changes over time for these particular patients who have completed the study. And this is for the vital capacity on the left and the FEV1-FVC ratio on the right. The diffusing capacity data similarly are shown on the left, and the total lung capacity on the right. Now, we did oscillometry during this study as well. I was hoping at the time this might be one of the first studies to do that, but you just heard Ivan's data, and I looked at PubMed this morning. There are now 18 studies out there when you cross-reference oscillometry and COVID-19, so people are certainly using this tool. The only difference we found between hospitalized and non-hospitalized patients so far is a lower reactance, suggesting an overall stiffening or lung volume effect of COVID-19 on the lungs. Interestingly, AX was quite substantially higher, but there was so much variability in that measurement, it didn't reach statistical significance, at least at this point. And when stratified by shortness of breath, disappointingly to me, we haven't seen any differences yet, but again, we've only analyzed about half the sample total. Over time, you can see R5 in the upper left, X5 the upper right, AX the lower left, and resonant frequency the lower right. And a lot of variability, but no major changes over time. It seems that wherever people are when they begin, they pretty much stay the same over 12 months, at least in our population. And just to show you the MIP and MEP data, maximal inspiratory pressure at the top and expiratory pressure on the bottom. Again, the sample sizes are smaller here, lots of variability. Data remain within the normal range in terms of normal values and don't change much over at least a 6-month period so far. And then very few data so far on P100 or P.1. We did find that those who were hospitalized initially had a slightly more negative P.1, which would indicate a higher drive to breathe. But at least so far, as you can see, first of all, no difference between those not hospitalized. And then secondly, it does seem to improve slightly over time. So this is something we'll be interested to follow up on. So in summary, what we can say so far is that gas exchange and exercise parameters were reduced in these post-COVID patients. The vital capacity and TLC were consistently lower based on severity of illness and somewhat with shortness of breath, but they were still in the normal range. And maybe there's a slightly higher drive to breathe. Regarding oscillometry parameters, certainly X5 seems to be panning out as picking up patients who are hospitalized versus those not. And maybe AX signal is there as well. And in general, I'm hoping that this might be a more sensitive measure than that of spirometry for picking up suggestive signs of restriction or stiffening of the respiratory system. So far, muscle pressures and respiratory drive haven't shown any differences. And of course, our data are incomplete, and this is cross-sectional only. I don't have baseline data on any of these participants, and our study size is limited by the grant resources that we had at the time. So I too have many people to thank listed here, both colleagues, Charlie Irvin, who many of you know, our coordinators, we have medical students and residents involved and biostatistician support. And again, my support for this study came from the University of Vermont Medical Center Foundation, our hospital grant foundation. Thank you very much.
David, thank you for a great talk. Very interesting for those of us who are taking care of these patients in our day-to-day practice and everybody else because of its coverage in the media. I'd invite Chung-Wei Chow from Toronto and Laura Gochia from Mexico City. Please turn on your cameras, your microphones, and lead off the discussion on COVID-19 and oscillation mechanics.
Yes, thank you, Doctor. Oh, okay, here we are. Thank you for both presentations. I want to ask both of you, if you, Dr. Kaminsky and Dr. Ivan, did you administer bronchodilator to the patients in order to see if there were a difference in these mechanical findings?
Yes, I'll let you know that I did administer bronchodilator for every one of these measures. And interestingly, we saw no significant changes in any of them. Ivan, I don't know what your experience was.
It's the same. Always our patient would put a bronchodilator. It's the same result.
Okay, and also I wonder if you make this, if you calculate the R5 minus R20 just in order to see if there were differences in the patients, and also if you compare the results with any reference values just to see if, I mean, from the oscillometry, just to see if there were low at the all of them.
We did look at R5 minus R19 in our case, and I didn't show those data just for simplicity. They did remain within the normal range, as did the resistance and reactance values at 5 Hertz that I showed you before.
Okay, thank you. And my last question with Dr. Ivan is, how you say that these patients were from the Omicron wave? Did you prove that they were Omicron or?
No, yes, we all our patients, the principal requirement for inclusion criteria need to be Omicron, because when we review the first literature, different animal studies show us that the infection is more in bronchus, not in lung. And our idea is, okay, probably this virus, this variant, could be similar to rhinovirus or syncytial respiratory virus and induce more hyperactivity than the all variants. That could be we need to change, is our opinion, to change the management, because now in our patient, probably we need more use of bronchodilator, probably corticosteroid, inhaled corticosteroid, and we need to think what kind of device we need to use. We need to use devices with a small molecule to achieve a smaller way, smaller ways. We think, for example, to use not turbohaler, we need to Respimat devices, and I guess that could be interesting in the future, how all these results put in the clinical practice.
If I can just add to that regarding bronchodilator, I was interested, Ivan, in that your results
because there was no time.
that suggest obstruction. But we really didn't see any signs of obstruction in our folks so far, because spirometry was normal regarding the ratio of FeQ to FEC, and the RV ratios were also normal, and we also measured specific airway conductance that was also normal. So I was interpreting our data so far regarding reactants and maybe area of the reactance curve as suggesting airway heterogeneity and also lung parenchymal stiffening as being the primary mechanical features that might be explaining the results. But maybe this has to do with the different variants, possibly, it's true.
In practice, sometimes the general physician are waiting for spirometry results. And we believe that we need to use not only spirometry, we need to use to measure oscillometry because we have more information.
I see that David and Jason.
Also, Dr. David Kaminsky, do you think that even though that you don't find probably the long term a big difference between the groups, did you notice like a trend that there's a group of patients that probably has low in any of the results a low function test over the time? I mean, probably there's a small group that persists with any problem.
Yes, thank you. As you can see by the error bars, we did have a lot of variability in all of our measurements. And indeed, there are some patients that are abnormal. What the problem is, I don't have baseline data on them. Some of them are coming in with concomitant disease, especially asthma, and a few patients with COPD. And so we're trying to sort that out based on chart review from previous records and so forth. But it seems to be a small number that are low. That's true.
Okay, thank you, Dr. Xun-Wang. I don't know if you have any questions.
Just a comment, but I see that David and Jason have had their hands up for a while. So I'm going to lead off with asking David to ask his question.
Great, thank you. Great talk, both of you. A question for David. Nice to see you, David, again. I'm curious, among your hospitalized patients, how many were vaccinated, and did you parse the data out by vaccination status?
Yes, great question. I didn't show that. Most of them were not vaccinated because most of our patients are coming in that average of 220 some odd days after infection, and the recruitment started in January of 21. And among the hospitalized patients, 10 of them had been on mechanical ventilation. So we do have a subset who were extremely ill and did survive. At the end of the day, I plan to go back and try to sort out among the hospitalized patients, those who received mechanical ventilation versus those who didn't. But I was still pretty struck by the fact that on average, results are remaining in the normal range. And I will say we have a long COVID recovery program here, and we have multiple patients who complain of shortness of breath now 2 years and plus after their original infection. And as many of you have probably seen too, lung function testing is normal. And in most of them, radiographic imaging is normal too. So there's something else going on. And that's why we added on muscle pressures and P100 to see if there's a drive to breathe issue or a muscle strength issue.
Ventilation perfusion issue, which would be much more. And that was my other question that you answered, was among the hospitalized, how many were ventilated? But it's only 10, so it's probably a small sample size to.
Yeah, we were lucky in Vermont not to be overwhelmed. So getting 50 patients total, 10's about right for those who are hospitalized.
And do you know the average duration of mechanical ventilation?
Yes, it was, I think, 6 or 8 days. So these were people who were destined to survive, if you will.
Great, thank you.
Thank you, Dave.
Maybe, David, if I can follow up a little bit on that, because I've been scanning a lot in terms of the COVID literature. The restrictive defects are very common, and I guess there are two issues. One is there are a lot of cardiovascular complications associated with COVID, and there's a huge issue in terms of, fatigue and muscle dysfunction. And so I'm really pleased to see you're collecting some of the MIPS and MAPS data, but are you or are other folks sort of collecting cardiac parameters in these folks?
Yes, I'm not in my study, but you're absolutely right. There's well-documented cardiac dysfunction. And now there's some very interesting data coming from CPET studies, cardiopulmonary exercise testing, that suggests there's microvascular dysfunction in terms of oxygen exchange at the level of the tissues rather than oxygen delivery. So there's a lot we still have to learn about COVID infections.
Jason?
Yeah, thanks. Very interesting, both of you. Something about your data that I noticed, David, and I've noticed this with other studies, is that your hospitalized patients were obese, whereas the non-hospitalized patients were not obese. The BMI is below 30. And as we well know, obesity predisposes to peripheral lung collapse, which can cause increases in AX and X5 and so forth. So I guess what I'm wondering is whether obesity, just because of the body habitus effects, might play a role in this. And the other thing is that if you have some perceived disability for several months to a year, you can have a lot of deconditioning that goes on in that time, which could, I suspect, masquerade as some of the features you see. So, of course, as you pointed out, it would be great to know what these patients look like before you got them, but you don't know that. So it's nothing you can do. But I wondered whether those factors could be playing into this.
Yes, Jason, as you know, we talk about this a lot, and that was one of my first thoughts, is maybe obesity is driving many of these baseline factors. Hopefully at the end of the day, we'll have enough statistical power maybe to sort that out and see if this is one of the primary driving features of the outcome measures, which are those oscillometry measures in this case. Regarding deconditioning, again, some of the CPET studies that have been done, not by me, but by others, are showing that patients are deconditioned, and as you would expect, and especially those who are hospitalized, and especially those who are on mechanical ventilation. So it's a very complicated issue of explaining their fatigue and their dyspnea on exertion.
Yeah, I know it's complicated. Well, great work. Thanks.
Thank you.
Xiangwei, I wonder if we could let Ivan have the last word, and we'll finish where we started, and then we'll move on to Zoli's talk. So Ivan, what have you to add to this conversation?
David, we found in patient after 2 years with COVID, in CT scan, we found ground opacity or some sequels, and all of the pulmonary function is normal. However, when we measure the oscillometry, we found a small airway alteration. Do you find this kind of patient?
Yeah, we're not doing imaging as part of our study, but in those who've had CT scans, I'm looking for that. And indeed, I agree with you. There are some patients who seem to have subtle abnormalities on imaging, even though they're having normal conventional lung function testing, and yet their AX or their X5 may be slightly off. So I think you're right.
It's because we think that probably the scare, I don't know if it produced a decrease of a smaller wave. And I don't know, it probably could be, or we have more mucus inside of the smaller wave. And probably we need to think about this if we want to management with the treatment in this kind of patient.
Those are great points, Ivan. I agree.
Well, look, thank you, everybody involved, David, Ivan, Xiangwei, and Laura. That was a great talk. My parting thought is I wonder if, Ivan, you partner up with some of the people doing structure function up here in the US and Canada, where we're actually able to measure peripheral airway counts using CT imaging, whether there'd be any signal there. It's now with great pleasure that I'm going to hand the podium over to Zoltan Antosh from Semmelweis and Zagreb in Hungary, who needs no introduction, obviously, to this audience. And I'm very excited to listen to this talk. This is a project Zoli and the Noise Lab have been working on for a while, and it's fun to see it actually progress to the point where he can unveil it. So you guys will be the first audience to see his work. And Jeff, you're going to put in perspective Zoli's new approach to intra-breath oscillometry. So Zoli, we see your slide deck and we'll let you get into presentation mode.
Thank you, Ron. Let's try if I can start the presentation now. Do you see it properly?
We see just the slide deck. We don't see the presentation mode yet.
Again.
Perfect.
Okay, thank you very much. Here's my declaration of a conflict of interest. So the background, one of the backgrounds of this study is that old findings can show us that at different lung volumes, the input impedance of the respiratory system might be absolutely different. So in 1975, Michael Zuns and his colleagues presented oscillometry data. Just look at the right-hand panels because it was still the transition from the impedance, magnitude, and phase angle presentation to the resistance and reactance presentation, which we favor now. So departure from the cardiac and blood vessel mechanics that time. So they made the subjects breathe at FRC -1, -2, +2, and 2.5 liters below and above FRC respectively. And there were huge changes in resistance, less marked changes, just the -2 liter reactance was substantially lower than the rest of the conditions. Next study was a few years after we addressed the mid-inspiratory and mid-expiratory impedance data contrasted with the mean values. Just two examples are given here. One is where these volume levels made a difference, and in another example where there were no problems, no differences at all. And they introduced the characterization of the resistance inertance compliance fitting to these data. Probably physiologically, the most elaborated study was from Leuven, Belgium, where Roberts and Van Doestein looked at the different phases of breathing, picking up resistance and reactance values at transition to expiration to inspirations, that is about zero flow. The other transition from inspiration to expiration, maximum inspiratory flow, maximum expiratory flow, half expiration, and pointed out quite marked differences with the volume changes or the instance of the breathing cycle. Both measurement sets were from the head generator technique and the conventional cheek support measurement. Huge differences can be seen, especially in the reactance values. But this is not the point of my talk this time. Even before, simple sinusoidal oscillations were used to follow the changes of respiratory resistance during breathing. these are the classical papers to show this. And now, the intrabed oscillometry, which was introduced a couple of years ago, pointed out that the respiratory mechanical disorders can be characterized quite nicely if you look at instantaneous impedance data instead of mean values of respiratory resistance in total breathing. And this is just a list which is, at the moment, it's enough to list on one slide, but hopefully it will speed up. So the fourth idea behind the study was that if single frequency oscillometry has a promise to look into the fine details of respiratory mechanics, the dynamics of impedance during breathing, would it be possible to extract similar information from the conventional multi-frequency data? So we did a comparative study in the same mixed patient subject groups, not the same measurements, because the 10 Hertz single frequency measurements were done after the 11 Hertz measurements, or more correctly, the 5 to 37 Hertz measurements, from which we extracted the nearest frequency, the 11 Hertz, the nearest to 10 Hertz. And, looking at the intrabed loops, like the resistance versus volume, reactance versus volume, data in healthy subject, an ILD, asthmatic, and COPD subject, just examples. So these are the 10 Hertz data. And in the very same subjects, we extracted the 11 Hertz intrabreath, which are characteristically very similar to the corresponding measurements, apart from the fact that they were not extracted from same recording. So they involve some intra-session variability of the patients. The most apparent difference is the noisy nature of the 11 Hertz data. But if many breaths are involved, just the mean values are compared, quite nice comparison correspondence can be found in the different intrabreath measures of resistance, like the expiratory resistance, Hertz and 11 Hertz comparison, very near the identity line, because between 10 and 11 Hertz, basically there is not much change in resistance. Either negative or positive frequency dependence covers just a minor change. And inspiration is very similar. These are samples of probably 20 subjects each, healthy COPD, ILD, and asthmatic subjects. We had more scatter in the tidal change in resistance between expiration and inspiration. That's what we call delta R. So that delta R 11 versus delta R 10 are quite not that strongly connected, but still a quite good R squared value. And the mean values, which are not intrabreath, but just the proxies of the conventional average impedance measures, there was a very, very slight departure from the line of identity. I'm not going through all these panels because reactance comparisons are also very interesting. But raise the question whether we can look at other frequencies in these composite signals, in particular in measurements which are huge, came from very nicely set up studies with many participants, and only spectral data can be extracted. Would analysis of the individual frequency components add the differences revealed or not revealed at the conventional oscillometry? That was the motive of our study. So we used export recordings, flow pressure time recordings from the tremor flow device. A big group of healthy adult subjects from Toronto. These subjects were basically measured prior to bone marrow transplant. They were all normal in conventional PFT measures and had no respiratory problems, no history of smoking, etc., etc. There was another group with asthmatic patients and the third group with COPD. These are yesterday numbers because I keep on adding more and more. So probably this cross-sectional status, which I am privileged to show you now, might change with larger numbers. We used these exports and analyzed it with a LabVIEW-based custom-made software, which was designed by Gergő Makan, my colleague here, and just show you a few slides on the surface, the user's interface, where we can look at the recording, identify the beginning and end of inspiration. This is a volume test, and below, dynamically from frequency to frequency, the resulting impedance data are displayed. Notably, filtering artifacts destroy the first part of the last part of the recordings, but they are carefully avoided. This is another shot showing the resistance and reactance data from a particular set of measurements with the end inspiratory, this is the red, and expiratory, black, maximum and minimum, this is the blue, values, and the yellow, which is the spectral average. This is the delta R, the tidal change in resistance with frequency. And the similar measures are searched for reactance. And these are the loop areas, the resistance versus volume loop, resistance versus flow, reactance versus volume, and reactance versus flow loops. So what eventually we get another surface, we can look at the individual loops, the 3D presentation. I carefully omitted the disturbing very close frequency points. So I only list now the 5, 13, 19, 5, 11, 13, 19, 29, 20, 31, and 37 for transparency. In general, the most scatter in the loop shapes are found at the lowest frequency. Sometimes we run into a very strange graph, which was explained soon after by looking at the individual recordings and spotting wrong artifact recordings, which escaped the attention of the artifact monitoring software and also the human component in the laboratory. So once this erroneous recording was rejected, the rest showed very nice looping patterns, the same shape from frequency to frequency. The mean values change a lot. This is the volume dependence of resistance. This is the flow dependence of resistance. I'm not able to rotate these graphs now because that would be a disaster for the presentation. And same thing for the reactance values. So the almost 150 controls, individual spectra were collected for each phase, the maximum resistance point, the end expiratory and inspiratory, and the minimum resistance. Also shown are the mean resistance, which is very, very close to the end inspiratory and expiratory average. And if these are the mean values with SDs, and if these for comparison are put on the same graph, we can see that the average impedance, which is the blue, is basically covers on the average for the whole population, the end expiratory, whereas the end inspiratory is much lower from both. The minimum can be fractionally lower than the end inspiratory, but the maximum can be substantially higher than the end expiratory. So these maxima don't necessarily coincide. Same scatter and mean as the plots are for reactance, which are not very transparent in this presentation. But if we put all these instants together, then again the minimum reactance, which is much lower than the end expiratory, which is the black, and the maximum reactance is even higher than the end inspiratory reactance. This is another group, asthmatics. So just look, let's look only the summary sheet, which we see minimum resistance totally looking normal. The end inspiratory, I would say, goes as a totally healthy impedance data. The mean value displays a big frequency dependence and a slight increase at higher frequencies, very close to the mean data. And again, the maximum resistance is much higher. The same for the reactance curve. The minimum values and the maximum values differ and cover a wide range, but red and black and inspiratory and expiratory is markedly different. Note also that while the mean reactance has a resonant frequency above 30 Hertz, this is shifted down to 15, 14 in the case of maximum reactance or end inspiratory reactance. So this is the phase where the asthmatics display most homogeneous lung mechanics, which results in a high compliance and an elevated reactance value. The COPD data were surprisingly very similar, so I don't go step by step here because I have a summary sheet where the healthy COPD and asthmatics are more or less on the same scale. Difference between the healthy resistance and healthy reactance data and the corresponding COPD and asthmatic recordings is quite obvious. What is not obvious at all, difference between COPD and asthma, where resistance gradually loses its frequency dependence, going to the end inspiratory phase compared to the end expiratory, both in COPD and asthma. Minimum values basically don't differ. It might be just a sampling thing, so it's a provisional small data set. Final differences can be expected if we analyze all the available data for us. Slight differences can be noted in the derived quantities. So this is the area of the reactance volume curve, which goes down with frequency but does not disappear. This area measure is a sort of similar indicator to the expiratory flow limitation index by Raffaele De Laca. Just the latter is a rectangular approach to this reactance volume loop. This is exactly the loop area. So this one is quite different from the asthmatics, where we don't have high loop areas. That is much expiratory flow limitation. It's much more milder. And also, if we look at the flow dependence of reactants, we see that COPDs behave quite uniformly, whereas the asthmatic population seems to split into two different categories, resulting in a slightly different mean values. But if we separate these asthmatics from these on, I don't know what measure, there would be certainly inhomogeneity in this population, which is probably true for all the subject groups we have seen. So in summary, I was quite surprised that the vast majority of the recordings could be analyzed into intra-breath measures with good quality, although the scatter of the IB measures was the highest at the 5 Hz loops. They were not very spectacular in most of the cases, but the average values derived from these dodgy loops were still quite consistent. The limitation of this analysis was that we were forced to take the bandpass filtering around each frequency very narrow, because otherwise 11 and 13 Hertz, the 17 and 19 Hertz, and the 29 and 31 Hertz, very close neighbors, contaminate the other. So probably the message is that these unfortunate close frequencies of one of these pairs should be eliminated, just because the prime number list is less relevant in oscillometry than in mathematics. A good message was that in many cases, the average loops were scattered and full of spikes, which were unnoticed in the original recording and not rejected. The average values were not basically different from the rest, but these extreme values demolished the nice looking pairs. So probably the quality control might in the future involve such a intra-breath graph painting the artifacts which were very, very amusing sometimes. So it was quite a revelation to find a little artifact hidden from the eye, but displayed by the looping. In this study, every interbed measure displayed a very marked, very solid and consistent difference, which was not shown in previous efforts of collecting multi-frequency data at different lung volumes. So it is quite promising. For this particular sample, which we analyzed by now, the asthma and COPD did not differ too much, but this is probably not only a selection of or availability of analyzed measurements, but probably the FEV1 and FVC selections or characterizations of this data are also mixing things, and potentially a good old hand, which helps us always define overlap syndrome. So thank you very much for your attention. I would thank first to Gergő, who did a marvelous job by putting together this software, which is very handy, very thorough and very detailed in relatively short time. And I also thank and Joyce from the University Health Network Lung Functional Laboratory to share these control data with me, and the same for Ron, who contributed contributed to the study with asthmatics and COPD patients. Thank you very much.
Well, Zoli, thank you very much for that amazing talk and framing so nicely, I might add, these concepts that many of us will be trying to wrap our minds around in the coming days and weeks, as hopefully we're able to maybe deploy some of this and see how it works, take it for a test drive, if you will. Jeff, please help us understand what Zoli's presented and put it into perspective.
Yeah, how much time do you want to spend, Ron? You're the organizer. We're closing on the end here. I know you're up next, so.
Well, it's okay. Take your time. I've actually made plan B. Some of us do have to exit for clinical work, but I've managed to find alternates who maybe have only their beds to go to after this because of time differences. So go ahead. Let's see where this goes.
I don't see any hands up. If there were, I'd give the floor to them, but I guess I'll start. Very remarkable and detailed work, Zoli, as always. Very, very neat to see those loops again here at multiple frequencies. I guess I have a question about the maximums. So if I consider a simple model of the respiratory system where I'm inhaling and exhaling and I just have a balloon in a bag, there's no mechanism for the resistance to be higher, the maximum resistance to be higher than the end inspiratory resistance, nor the reactance, I guess, although the mechanism would be different, be lower than the minimum if it's just due to changes in volume or changes in stiffness due to the nonlinearity of the lung. So it must be a different mechanism. So is it associated with, unless it's artifact, is it associated with, say, peak flows and flow limitations? And I would expect that for the reactants. But I guess I expect that now, seeing your data for the resistance. Is that the mechanism why maximum resistance is higher than end inspiratory resistance? End expiratory resistance in your loops?
Absolutely. So there's a very marked flow dependence, which follows the Rohrer's V shape in principle, but it's U-shaped, and probably it is the change between the minimum resistance and the maximum resistance, either taken from the peak expiratory flow and the peak inspiratory flow statistically in adults, mixed populations, not exactly this. It is approximately 50% change. In infants, this goes up to 80%, just because the nasal, very nonlinear nasal pathway. So that clearly points to the fact that it is sometimes at the peak flows, whichever, sometimes symmetrical, sometimes expiratory flow generates higher resistance, or rarely, not in infants, but it is very common. The inspirative limitation raises the resistance much above the mean level, I would say.
Right. So quickly, it raises the question or the possibility that the moment of peak flow, which we anticipated to be useful for diagnostic purposes, at least Raphael and others did in COPD, but because the same is true in asthma, peak flow resistance, peak flow reactances seem to be useful, surprisingly.
Yes, in a way, yes.
Yeah. Anyway, I see David's hand up. David.
Zoli, very nice to see you. Great talk. One comment and then maybe a question. One, looking at your intra-breath variations and reactants for the COPDers, I noticed I didn't see a lot of big variations that would indicate dynamic flow limitation. So I assume these subjects were not or did not have severe COPD to the point where they would exhibit expiratory flow limitation. That's maybe a comment. My question is, I noticed, I did think there was a lot of variability, intra-breath variability at the extremes of your impedance spectra, the low frequency and the high frequency. It seemed the minimum occurred around the resonant frequency, which is interesting because if you consider impedance in polar coordinates, that's where the minimum is going to be. So I wonder if you could comment on that, and maybe give me some speculation as to why the lowest variability would occur around the resonant frequency.
Yes, that's more or less, with many exceptions, true. So when the resistance takes the minimum at that frequency close to the resonant frequency, the variability or the SD is smaller. But if you divide it by the magnitude of impedance in that frequency, the coefficient of variation wouldn't be smaller. Even higher, because if the variability in resistance or the intra-breath change from the minimum to the maxima is upper airway stuff, then probably you recover it at any frequency of the oscillation spectrum. So that would probably preserve the shape of this upper airway behavior. We were wondering if nonlinearity is deep in the lung, like in COPD, the expiratory flow limitation. Would this pattern be preserved if we look at the higher frequencies only? And the answer is probably yes.
Okay.
This proportional change in the loop area, but the same pattern and the collection of reactance data at low flow rates, that is a preserved feature of COPD.
Yeah, the way I understand why flow limitation would change during the breathing cycle with volume is you're basically exploring, as the diameters change, different regions of the lung. You're going down and you're going up in the lung. And the oscillations, this is the way I interpret it, and correct me if I'm wrong, but the oscillations only see the soft parenchyma behind these sites of flow limitation if the flow limitation is absent. In other words, there's the possibility for laminar flow from the oscillations deep to the alveoli. And if you don't get that, the oscillations are essentially filtered, blocked because of the flow limitation during expiration due to the slightly increased flows. And it varies as you're breathing. And so you get to explore, depending on the breath size, different regions of the lung. Makes me think that maybe we should occasionally ask them to breathe a little more out or a little more in, larger volumes. We could get to explore more interesting behavior than just the normal breath. Anyway.
Yeah, that's
Jeff,
right.
I was going to wonder if we could draw parallels from some of the functional imaging work that's been done. As you know, Grace's group, as some of the others have shown, I think also Jeff Wild and Sheffield, amongst asthmatics, when they go into and out of exacerbation, certain asthmatics will have a signature area of the lung that will go down and become dysfunctional and show up as a deficit, a ventilation defect. Whereas other asthmatics seem to have variation from exacerbation to exacerbation, which area is going to be non-functional. I'm wondering if something similar could apply within a same session. If you have very unstable airways, could on some breaths, some areas of the lung be poorly ventilated and then recover, and while other areas would then go down within the same session. That may be too short a time frame to pick it up, but I throw it out there as speculation to you guys who may be more knowledgeable in lung mechanics. Crickets.
Crickets. I know Altus looked, if I'm pronouncing the name correctly, that in asthma, the defects were persistent over short time frames, but varied over longer time frames, like weeks to months. And the persistence was actually much more surprising than the fact that there was variation that changed. So the amount of persistence in a defect in an asthmatic from minute to minute, from hour to hour, from day to day was, it's not always there, but it's remarkably consistent that parts of the lungs that have defects seem to recur, eventually changing over longer months. I don't know if it changes within the interbreath from breath to breath, but it does, of course, if you take big breaths, as Vanessa Kelly showed. If you start doing very slow volume maneuvers and go down, you move what airways are open and you change reactants dramatically to more normal levels as you inhale from very low volumes going up to higher volumes.
Just a comment that nature has made it possible for us to look for the optimum breathing pattern during any bad condition. So I don't know that intrabreath would be wiser than what we do, but it's certainly true what you said.
Do we have time for Jacob there, Ron?
Yeah, we'll do Jacob as the last question, and then we'll move on, and I'll make an abbreviated last talk after this.
Thank you. I guess this may be more of a comment, but I first of all, thank you for the presentation. I find this fascinating. I think one of the great benefits that comes from taking measurements at multiple frequencies is being able to do some fancy inverse modeling and try to fit something that tells us a little bit more about what the structure of the lung could be, or gives us some more parameters to interpret. I'm wondering if that's something that can be done with this type of multi-frequency intra-breath oscillometry, and what your thoughts are on that. Thank you.
Thank you very much, Jack. Let me reflect that probably the optimum signal should be found. So get rid of these stupid twins of signal components, and then probably they will be far enough from each other to expand the filtering range and extract more side lobes due to the intrabreath dynamics. That would help a lot, I'm sure. But we're working from a pool of commercial outputs of oscillometry. And the result was probably not disappointing. I expected far worse, especially from the not very regularly breathing healthy persons. And I have to add that this situation is dramatically changing if you go down with fast breathing kids with the same signal, and especially if they are sick. That the situation is not that nice in all children.
Yeah, I have the fortune to know that the Thoracis has released a new waveform that doesn't include those matched close frequencies. So if you don't have this already, for those of you that Tremoflow, they will provide it if you ask. It's available for clinical use.
Okay, well, that's actually a great point a great point to end the conversation. Industry, if you're out there, this is a plea to give us the pruned frequency spectrums that we've been asking for a while, whether you're, no matter what manufacturer you happen to be. And Zoli, thank you for sharing with us your work and looking into the possible future of oscillation mechanics. It'll be interesting to see how this story unfolds in the coming few years. So with this, I'm going to then take over the podium and share my screen and briefly go into the last roundtable discussion, which will be presentation mode. That should be it. Jeff, confirm you can see my presentation mode?
Yeah.
Good. Okay, so because of time constraints, we have a few substitutions. Chung Wei Chow is going to sub in for Shannon Simpson and Paul Robinson for Dave Kaminsky. So they'll join me on the podium in about 60 seconds. This will be an overview of what is still missing, and it's based on the paper that David and Shannon spearheaded recently, looking at the applications of oscillometry, and I would refer you to table 2 rather than make you squint. I've done a modification of table 2 with my own personal laundry list of what I think needs to be done. And just to go through briefly, no surprise to this audience that harmonization of devices is number 1 for me. And whether it's hardware, software, signal processing, it's probably all. Certainly the impact that the non-harmonization is having on clinical studies and normative data needs to be addressed. And also a plea to industry, please standardize the graphics so that we can have effective report interpretations between institutions. Normative values, we've been talking about that a lot this conference already. Phenotyping of disease, I was happy to see the Toronto group. Chung Wei, thank you for validating some of the patterns that I had proposed earlier. It's nice to see that going into the literature. Other groups such as Simon Zikis and Lester's are finding exactly the same thing and need to publish it. Minimally clinically important change, bronchodilator response, standardization of bronchial challenge protocols all needs to be done. And for a guy working in the trenches, those of us who are in everyday practice, we need to be able to grade the severity of the disease depending on what disease we happen to be working with. Monitoring, whether it's in the office, visit to visit, or at home, needs to be available for progression of disease monitoring, therapeutic response monitoring. We also have an educational issue. There are a number of myths that are even in some of the editorials of major journals that need to be dispelled. We need to have solid undergrad, postgrad, and CME educational programs in place, such as the workshops we're doing with the ERS, the videos that have been out, some of the Job videos that have come out from the Toronto group and another group using the RESMON should be viewed, and guideline inclusion. Very practical for those of us who are doing clinical practice, billing codes, and also emerging applications. And there's a long list of things, of different disease categories and applications, including the intrabreath we've just heard about. Being a practical kind of guy, for me as a clinician, these are the 3 big things that really need to be done to make it workable. No one's going to use it in everyday practice if they can't bill for it. That's the reality. The guidelines need to be supplied with enough good data so that they can make a recommendation if that is going to be the case. And as I said, the validated patterns of oscillometry findings really are going to help the busy clinician at a glance see what's going on, because he's not going to have time to do the full comprehensive analysis that we do in the research world. These are just some examples of some of those things I've mentioned. Chung Wei has formulated a very nice standardized reporting protocol for the University of Toronto. These are the patterns I alluded to that I've seen that have now been seen by other groups. In the absence of any staging for COPD, I've made my own, and this is what I use in my practice for better or for worse, completely unvalidated, but we need to start somewhere. And then finally, some nice work from the Australians showing how monitoring, and in case this is the long paper of home monitoring, you can see 2 time samples of oscillation mechanics at home during a period of uncontrolled versus controlled asthma. And these are just anecdotes of some of the things we need. So I'm going to ask everybody to turn on their cameras and their microphones and ask Chung Wei and Paul to lead off a roundtable discussion, which won't be as long as we had hoped for. But anyway, let's see how far we can go and how many people will stay on for the next 5 or 10 minutes.
So Ron, thank you very much for sort of summarizing a lot of this. And I agree with you. I think that, you know, as someone who's actually used oscillometry a lot in a research study, probably the biggest thing is the harmonization. There's a lot of work now with the development of the normative values, but I think the education piece in terms of dispelling the myths of oscillometry and actually providing a lot more education and in terms of both what oscillometry can do, what it measures, and a lot of the quality control standards for the actual collection of the data is going to be really important. And obviously with everyone here, I think the having good quality data that is published will do a lot in terms of leading the way for wider application of it in clinical practice. I don't think, Ron, that we're going to be able to convince anyone to replace the billing fees for oscillometry and replace it with something else until we can show excellent data that it is measuring something that is reproducible and clinically relevant. And certainly in Canada, and I suspect in many other countries where you have a publicly funded health system, no one's going to give you a new billing code without replacing something that you think is not as good as oscillometry. So I'm going to leave it at that. And I think, Paul, you're standing in. And so, you know, the Australian Canadian system are very similar. And your thoughts on that?
Yeah, I mean, just to add some of those points, Chung Wei, I think the normative values, it's great to see so many people collecting really strong reference data. Talking to Shannon recently, the efforts to combine available data sets in the GLI approach was very much underway, and there's still a lot of enthusiasm to finish those off, and I think they'll be important. And it'll be really interesting to see whether that can help. You know, whether it is possible to combine data across different devices to come up with harmonized equations, which I think will help, because certainly for me, I think when we're looking to try and incorporate this into clinical practice, it's got to be a simple test, it's got to be simple to teach, it's got to be simple to understand, and in busy clinics be feasible for them to do. And I think there's a huge amount of potential for that. I'm really heartened by not only the fact that there's been a lot of presentations on really good research studies, but also a feeling that people are building real world experience of using it. And my plea to them is just to make sure they try and do it in a way where we can learn a little bit about how these results relate to clinically important outcomes as we move through, because that's what people really want. I think the clinical applications document is a really important step forward, and I know David and Shannon aren't here at the moment, but I commend them highly for leading that, because I think that was great, and hopefully that can then maintain the momentum to be able to come up with the data we need to be able to inform how best to use this test. Are there any other comments that people would like to make from the audience? Moving forward, I can't see hands up at the moment, but I suspect if people just want to say something, they can probably say it. Ron, I'd also say, I mean, it was great to see so many countries represented. and so many different groups represented across these 4 weeks, which shows that I think there is broader kind of interest in this technique.
Sandeep.
Yeah, I just wanted to say that this was an absolute academic feast for us in India, because we have been introduced to the lung oscillometry, respiratory oscillometry for a short time, and I see a huge potential in India, and the sort of presentations that that we had over the last 4 weeks were absolutely amazing. And I think these are very exciting times in India. At least there's a lot of noise about the application of respiratory oscillometry in clinical practice, and I think as the knowledge base increases, there'll be much wider applications. And as Ron very rightly put in his last slide, the future, I think it's a wonderful roadmap that he has set up. And I think once we sort of start harmonizing, then I think it'll be a complete game changer in the field of lung function testing. And very grateful for such wonderful presentations.
Thanks, Sandeep. I think your work from the Omega group, I mean, certainly in my mind, was a really nice illustration of just seeing what's happening in different countries and what's happening on an impressive scale as well. Laura, I can see you have your hand up.
Yes, thank you, Paul. Well, I think as you are saying, something very important is trying to understand how the different devices works, and also how the different manufacturers can make that we could have a same number. I mean, we cannot do reference values for all the devices that are in right now. It's difficult, and I also see that there's a lot of problem also for grants to do research right now in different countries. For example, this point of phenotyping of disease, we are trying right now with other friends in Latin America to do oscillometry to any patient that comes to our clinic that comes for spirometry or other lung function tests, but that we know the diagnosis in order to see which of the different values of oscillometry are changing according to the disease. But I think that probably we need to share a little bit more, or to invite people through this oscillometry summer camp to put data together in these other things. I know that the GLI is right now collecting normal values for the big reference equation, but also for these diseases, I think will be important. So as Dr. Chung-Wei say, we need to demonstrate that it's working better than other tests that sometimes we think that they don't work very well, but still using them.
I just might add that, people get into this dichotomy of spirometry versus oscillometry, and I think this is to be avoided. They are tests that measure different aspects of lung function. They are not mutually exclusive. I think what we need to find out is their relative places. And it may be that the sequence in which we do this tests needs to be established, and the proportion of individuals that undergo either oscillometry or spirometry needs to be established. And so I see them as complementary, and it may be that one will be the screening out in the field, and then we have to bring in and confirm with the other tests, something along those lines. So I don't think this is a battle of either this or either that. And I think we have to be careful to frame our conversations, because it's so easy for people to think that that's what the issue is. And then, of course, people tend to choose sides and close down their minds. I don't know what other people's thoughts are on that.
Yes, I think you are absolutely right. I always think that it's a complement of other tests. Here in Mexico, for example, there are adult doctors that are using oscillometry when they don't find a change in the spirometry, for example, test in COPD patients or asthma patients. They ask for the oscillometry, and then they find that something is happening there. But I don't know you, but with the new standard of oscillometry, when they put this 40% of change with bronchodilator, some doctors said, well, these patients were obstructed 3 months ago, and that with this new standard, they are not obstructed. So those kind of things make confusion for them. So, well, I agree that we need to learn a lot of things about it.
Well, I'm wondering if we could draw Dave Kaminsky back into the conversation, because I know David had to go because he had a clinic. However, his first patient is late, and so he's just signaled that he's still online. David, are you there?
Yeah, I am here. I don't know if you can hear me or see me.
We do. We like your mask. Very, very flattering.
Well, luckily my office is very close to the clinic. So I'm in clinic, and of course my first patient is late. So I decided to hop back on by iPad here. I just caught the end of the conversation going on now, and I do agree that oscillometry and spirometry are complementary. I totally agree with that. Although one comment I made to Ron in the chat before I left was, you know, we have a hard enough time just getting primary care doctors to do spirometry, to believe it's a real tool, it's an important tool to help with diagnosis. Introducing yet another tool to them is going to be challenging. Now, granted, oscillometry is easier to do than spirometry, but then again, we don't have a firm handle on interpretation, cutoffs for bronchodilator, bronchoconstrictor response, and so forth. So I think we're heading in the right direction. I think we have a lot of work to do. And Ron, I know you shared that table from the paper on interpretation. That's, to me, the most important part of that paper, is showing all the different ways we have to go, how much work there is to do to try to move this more towards clinical practice.
Yeah, it's amazing. If you think back, David, if we go back in time, I mean, spirometry, the timed indices, late 40s, early 50s, there wasn't really a good alternative around. So without any kind of validation, it was adopted. And then, of course, it naturally generates the longitudinal data that we've come to know and love because we've been raised on it like mother's milk. You know, I always wonder, had the computational requirements for oscillometry not been so great, or had we had personal computing available in the 1950s, would things be otherwise? What if oscillometry had been the first one there where there was nothing and it was filling in the void, and then spirometry came along as the test that had to show itself better than oscillometry to find its place in clinical medicine? It's kind of a bit of conjecture, but I think it's an important question, because sometimes things get entrenched into medicine for historical reasons, and then we think that there's no alternative. So the challenge for me is just opening people's minds. I don't know what's the end will be, but I think opening your mind is the first step.
Agreed.
I think, Ron, just to add to that, I think sometimes the easiest place to be able to show utility of something is when you can't do the other test. So certainly from a pediatric point of view, in children where you can't do spirometry or they're not good at the technique, there's a lot of interest from a broader kind of, and I talk about people within the respiratory function unit and other physicians, to be able to have a tool which actually provides some information when you have none. And then the hope is in those populations where you can do both, is that we can start to show the clear benefit of adding in the additional test. And that may be a bronchodilator response that's missed by spirometry but detected by oscillometry. It may be a challenge test, along those lines as well. I think those may be the doors into getting broader uptake, and then it expands from there. I can see we have one hand up from our earlier presenter who is presenting from a COVID point of view.
That would be Ivan, I think. Ivan, your hand is up. Do you are you having something would you like to chime in?
And then if we have time, I'd like to ask Chung-Wei a question after that.
Ivan, did you want to say something? Because your hand is up.
Yes. Thank you. I would like to use the same word that Professor Soltan used. Oscillometry Nostra had prepared a paper. In this paper said what the oscillometry application. Now we have, in the future, probably we had a lot of patients with post-COVID. I believe that is the great opportunity to be preparing what could be the future application of oscillometry in post-COVID patient, because this is a lot of interesting results with a lot of research that interesting to work in this topic, and I guess that could be a next challenge for all of the group to prepare a guidelines about this.
And also importantly, not a test that's not necessarily viewed as aerosol generating, which is helpful as well. No, I mean, I think that's a good point. I think COVID is an exciting area where this may have potential utility. If you don't mind, I do have a question. Chungwei, Ron showed that clinical interpretation report that you've put together, and I noticed on that there's a lot of variables listed. And one of the things I wonder with oscillometry is there's a huge amount of variables it can generate, and that can be overwhelming for people that don't have an in-depth knowledge of the technique. How have you found others within your department have taken to the huge list of variables, or do you find invariably what you do is actually just concentrate on a couple to then try and show the utility? Because certainly from a multiple breath washout point of view, again, a huge number of variables you can generate, but we get the most success when we concentrate on one or two just to try and get the uptake there.
Yeah, no, that's a really good question, and a very good point, Paul. I think that, we had generated this really for our own personal, our own research group personal use. I think there are two components to that, and sort of taking the analogy from the pulmonary function studies that we and Zoli will add in, but sort of taking in the pulmonary function studies. There are pulmonary function studies, as I'm sure yours are standardized, but there are also a whole bunch of values in there that most people don't actually look at or even use. And so, we tend to sort of focus on a couple of things, but I think that the big thing I would like to take from that interpretation strategy is actually the standardization of the axes, of the X and Y axes, so that you can actually compare between different patients at different times. I think the importance of actually looking at having both the reactance and the resistance curves on the same panel is very helpful in terms of, because they tell us two different things, right? That they tell us different things about what the respiratory mechanics. And when we generated that list of the variables, I was fully expecting that those things will change over time. And with some of the work that we have seen today, and with a lot of the work that Zoli has presented, I think that a lot of the work and a lot of the things that the parameters that are going to help us differentiate between different disease states are probably going to be a combination of both the spectral and the intrabreath oscillometry. And so I fully expect that over time that those things will change. And then I think that the other key part, of course, is that as we have more reference values available, is the sort of the denotation of where our reference values come from, and the ability for us to actually update or regenerate those predicted values as more data becomes available. So that's sort of my 2 cents worth. But I also think that, I agree, Ron, that, I think that oscillometry complements a lot of the other, lung function assessments that we have. I think and I see a big part of oscillometry as being very useful in terms of screening and being accessible to many, different groups and financial ability to do things, as well as how quickly it is. But it's going to be really key that we really do it correctly. And if we don't teach that, then, we're sort of up the creek, because people will find it not to be useful.
Yeah.
So Zoli, you had your hand up earlier.
Your mute is on, so please unmute, Zoli.
or you were waving to someone.
But I was waving to Ramon when he left. Sorry for that.
Yeah. To Paul's question as to how do you deal with the multitude of variables, I liked your answer that, well, spirometry has a multitude of variables, and we tend to deal with just a few of those most of the time, occasionally looking at others. But my list, for what it's worth, I like R5, low frequency stuff. I like R5 minus 20. You know, I don't really care if it's R5 minus 19 or R5 minus 20, but R5 minus 20, because that's a measure of heterogeneity. So it's independent from R5, which isn't heterogeneity by itself. And then I like X5, because that's usually associated with stiffness of the lung or recruitment of the airways, if you're looking at asthma. And AX is very similar to X5, and either one will do. AX is preferred sometimes because it's tends to be less variable or more variable, as we saw today. I don't know. It's supposed to be less sensitive to breathing noise at low frequencies because it uses some of the higher frequencies. But X5 and AX, I think they're equal. And after that, I'm not interested much. I think the interbreath stuff is going to be very interesting to me now for research, but it's going to take a little while before it's used clinically or promoted. It will be promoted for a long time before it's actually used clinically. My opinion. I don't know if that disappoints anyone.
Just to a certain extent, with certainly our clinical reports, we focus on those 4 variables that you just mentioned. And then the reality is what we do in our research studies and in our clinical is we're actually still compiling all of the variables that Chung-Wei had listed on hers. So in some ways, what we're doing is kind of a combination of those 2 approaches. I think it's probably the approach that Chung-Wei was talking about before, where you may have a few that you concentrate on, but you're collecting all the others, because if you see additional signal or additional sensitivity in a particular condition of one of the intrabreath parameters, or that you've got the ability to actually identify it. But I agree with you, Jeff, in the sense, I think for incorporation into the lab, where you're asking lab staff to look at values, and then physicians who are who are oscillometry familiar, but not without any expertise, is I think being able to focus on a handful is a real advantage.
And I think Laura has a question, but before, I think the other thing is really, like, people can very easily conceptualize. They understand what an FEV1, what it measures. They understand what a lung measure, an FVC measure of the lung volume. And then when we start talking to them about the resistance and the reactance and the area of reactance, you can see the eyes begin to glaze over. And so it really behooves us to really explain a little bit better what those metrics measure and how they complement the other lung function assays. So Laura.
Yes, absolutely. And also it's like in spirometry, we have a lot of different values that we can see, but we are just using FEV1 and FEVC. So I think in the future, we are going to download to probably 3 or 4 of the values, but also I will include in this proposal that Dr. Ron is doing is the quality control, because for example, all the devices comes with a resistance that we just put it in there and see that it comes with the same number. I think we need to measure some linearity in the devices, because for example, for iOS is 0.2 kilopascals per liter, I think. But what happened in patients that are having 1.2 of resistance in kilopascals? So I think we need also to have this quality control. I know that there are some studies that says that it doesn't matter if you put your hands in your cheeks or not, or somebody else do it. But I think that, for example, in small children, if they are doing this, probably the reactance or the force you make in your cheeks are changing something in the measurement. So the quality control, I think, will be very important because I don't know why in two devices that use the same technology, like, for example, loudspeaker, even the same company, there's difference between the results. So I know that there are some biological things that can make that difference, but I really think that quality control will be very important in order also to apply those different reference equations.
I think that's a good point, Laura. The other thing, just as a general point about the technical standards that was updated in 2020, and then the clinical applications document that appeared recently, is whilst they're not truly living documents, certainly in terms of the technical standards, there are mechanisms by which they can be updated intermittently. Cindy Thamarin, who's not here today, she certainly led a publication last year that looked to update the bronchodilator thresholds with a few of us from the Woolcock on behalf of the group. And I think that's a really nice illustration where we can help to build momentum. If people notice a few other studies that come out that shift our thinking and make us think that actually we can revise a threshold, that we should be thinking about doing that as we go along, rather than assuming that the next technical standards can't come out for another 10 years and therefore it's just going to be a mix of publications in the meantime, because that will help give people confidence in the thresholds that we're suggesting. Are there any other comments?
I think at this point, I'm going to close the meeting down, Paul. David's patient has shown up, and I know that I have patients waiting for me. So although I was teasing him that people are more tolerant on this side of the border about waiting for their doctor, there are limits to which I can actually push that. So please stay in touch with each other over the email or whatever medium you want to use to take these continue these discussions, and hopefully we can pick up where we left off in person as we get back to regular meetings. I know myself, I'll be attending ATS and hopefully jump-starting or restarting the harmonization project. So everybody, thank you very much for your continued interest and participation in oscillation mechanics and the 6th annual Montreal Oscillometry Summer Seminar. And I look forward to organizing next year's, the 7th, in person, and look out for emails soliciting talks and suggestions. So everybody, thanks again to all our moderators, all our speakers, and those in the audience. Take care and please be well. Bye-bye.
Bye. Thank you.
Thank you very much, Ron, for all of this work. It takes a lot of effort. You've done well.
Thank you.